um, Master in Health, Master of Health Administration, and he's going to talk to us about the recent innovations for common hospital problems, talking about innovative solutions to all hospital problems.
Is that this one up there?
Yes, yes, yes. Thank you very much. Well, it's nice to be back in front of you, and as I said before, I enjoy this opportunity and value our partnership. Dr. Tamimi asked me to come to you today and talk to you about how some health systems in the U.S. are addressing very common, mundane problems through innovative approaches and the activity of their innovation centers. So what I did with this presentation is really hopefully be able to take you and back into the world of innovation, but really the mundane or the real-world applications. Then at the end, I went to a health organization in town by the name of Health Partners. They own their own health insurance company, they own their own hospitals, they have an integrated medical group much like yours, and I asked them to give me a practical example of some of the things they're working on, so I'll provide that to you, and it's the treatment and management of diabetes. So what I have here is just a handful of examples that I know from our interaction with students here, your colleagues, have some application as you think about what you might apply some of your innovation work to. And remember, I think one of the main points of my last talk was that innovation has to provide value to the organization, so the innovations that are funded have to be in a context that further the goals of the organization as it moves forward. So what I did here is assemble several challenges faced by health systems in the United States and some of the innovations that they're applying. So this won't be earth-shaking presentations, but it represents sort of the mundane, a lot less fun than neurosurgery simulations, I might add. The first challenge, just bed turnover rates. We talked about in my previous presentation the notion of capital asset efficiency. For example, a comparable hospital to yours in the Twin Cities would be Abbott Northwestern Hospital, about 500 beds, tertiary, quaternary referral center, would do all the things you would expect them to do. They're the largest cardiac center in Minnesota, even doing heart transplants. When you add it all up, average length of stay for all cases, these are very high acuity cases, probably average length of stay 3.9 days. You may move up to to maybe 4.1 for heart surgeries. I mentioned 3.9 in my earlier talk. But the question is why? Well, the why here is they want to turn the beds as quickly and as safely as they possibly can. Patients in hospitals too long tend to contract infections and complications. So not only do you get better, safer care, but you're also, as we say in our class training, turning over the asset faster. So what are some of the innovations to address that issue? This particular hospital and many others have moved to 24/7 hospitalist programs. So all inpatients are managed by physician specialists for the hospitalist program. Some other innovations, early discharge planning is the first day of admission. The discharge planning begins, including the disposition of the patient at discharge. In other words, a more fundamental question is, do we have a place for them to go? Do we know where they're going to go post-discharge, and will that be an effective place post-discharge? We talked about defined clinical pathways, managed step-down discharge capabilities and facilities. I know in my own organization, one of the problems we had in orthopedic surgery was if you actually looked at our volume management, our volumes were high on Monday mornings, as you might expect, and they dropped off by Thursday afternoon. The issue was not physicians who wanted to operate Fridays or Saturdays. The issue was not staffing. The issue was not facilities. The issue was we didn't have a discharge opportunity that was safe for the patients. So no orthopedic surgeons wanted, unless emergencies or trauma, emergent trauma, wanted to do a procedure on a Friday and then have the patient not be able to be properly attended on Saturday and Sunday. So patient, that's the bed turnover rate issue. The same issue applies to the intensive care units, whether medical or surgical. Again, ICUs being staffed by medical and surgical intensivists, and for the surgical intensive care units, we, for example, had all physicians attending the surgical intensive care were all trauma surgeons. So a different staffing plan, a different application of physician resources, a subspecialization of physicians hired for those particular efforts. The other physicians would be called in as consultants, but the intensivists, whether it be surgical or medical, would actually manage the case and also manage how surgeons or how consultants were used. One of the issues we've talked about here, and we certainly have in the United States, is clogged emergency rooms. When you really look at the emergent cases of hospitals across the United States, depending upon their level of sophistication, upwards of 50% or more of the cases being seen may not actually be emergent cases at all. In fact, in the United States, we have overuse of emergency rooms simply because many people don't have insurance coverages. And it's easier for them to access care through an emergency room because they don't have insurance coverages, because they are less likely to be turned away from an emergency room. So we have clogged emergency rooms. What are some of the innovations that have been applied to those? We're starting to see an emergence of freestanding emergency rooms. These are very sophisticated ambulatory facilities that are located away from hospitals. They may be up to 10 miles or more away from a hospital, but yet they are staffed as emergency rooms. They are equipped as emergency rooms. They have board-certified emergency room physicians in them, and in fact, they're seeing, and they have the ability to transfer quickly as necessary. What does this do? This unclogs or helps unclog the referral center emergency rooms. They can do a fair amount of urgent care to be distinguished from emergency care. They really don't have, and as I looked at the case mix of these, the case mix really doesn't differ dramatically from the emergency rooms that are embedded in hospitals. Also, we're starting to do a lot in the United States with e-visits. There's a company, this Health Partners, which is a delivery system, has created this virtual emergency or urgent care system where they can take care of a number of things by computers. And third, and this is one thing that Dr. Tanimi and I have spoke of at some length, the whole notion of owning the primary care network. Most large health systems in the United States that are integrated like yours, in other words, multi-specialty hospitals and physicians together, actually own and control the primary care delivery system out there. The ratio of primary care physicians to other specialists is usually around 40%, meaning of all the physicians in the health system, about 40% are primary care, depending upon how you want to define primary care. And the ability to own and control and manage the primary care delivery system allows you to do a number of things that has a direct effect on the emergency room. First of all, you can place the primary care satellites, as we would call them, strategically in geographies as far away as you would like. Our health system had primary care clinics up to 150 miles away from our major medical center. They were branded with our name. All the physicians in there had to qualify as members of our physician group. We had electronic connections with them. They all shared the same electronic health record, and the consultants or the specialists would develop specific protocols that would help the physicians, the primary care physicians, manage whether they referred somebody in or not, and likewise, on the other side of the coin, when to refer or send patients back from the specialist to be managed by the primary care physicians. So a fundamental difference in the health system configuration from a system, for example, that I ran, which was similar to a KFMC, would be we would own and manage our own primary care network, which allowed us to manage supply and demand, and consequently that had an effect on our emergency rooms of making them less clogged and and more efficient. Higher readmission rates. As I talked about earlier, and I used the example of heart failure earlier, one of the problems that many health systems are facing in the United States, those that are less integrated, more fragmented, is what's called an avoidable readmission. If you take a look at some of the Medicare data out there, you will find that a very high percentage of heart failure patients, once discharged from a hospital, are readmitted within 30 or 60 days post-discharge. That readmission usually has relatively little to do with the disease process and more to do with the fact that nobody was managing the patient post-discharge. So consequently, the patients aren't taking their meds properly, aren't adhering to their regimens. The only alternative left is to readmit them to the hospital within a 30 to 60-day time period. So what's going on in the area of innovation for avoidance of avoidable admissions? Standardized discharge planning. Patients are assigned to care teams as they are discharged. For example, our organization would have every heart failure patient assigned to an advanced practice nurse. That advanced practice nurse would take care of a number of patients post-discharge. We had telescales where they would weigh themselves every day, and that data would be transmitted to our organization. If the patient was not compliant weighing themselves, they would get a telephone call from us. The patients then had almost daily interaction for at least 30 days post-discharge, and for one 6-month period, at least one 6-month period, we reduced our avoidable readmissions to 0. Also then, we're seeing more electronic connections with patients post-discharge. Another issue that most, if not all, health systems are dealing with in the United States is a shortage of primary care physicians. That's the issue I talked about earlier, where in many organizations they've decided they will have to triple the patient panel size, going from somewhere around 2,500 patients to a primary care panel to upwards of 7,500. Well, you can't simply have physicians work more hours and work harder. They have to work differently. That's where the innovations are starting to occur. Now, it takes 3 major components to create those innovations. You have to have advanced practice nurses or physician extenders working with the physician as a unified team. The Allina Health System in the Twin Cities suggests that the best configuration is 1 primary care physicians and 3 physician extenders. That team is facilitated or enhanced by an electronic health record, standardized protocols for prevention and management of chronic disease. That's the second component. And the third component is actually the compensation system, where many of the primary care physicians and specialists, even in the more integrated systems, are compensated by a production-based model. The more patients they see, the more they get paid. So believe it or not, one of the most important clinical innovations that's transpiring in the United States is the transformation of the physician compensation systems. So I have a paper being published on that, which I'll share with my students here. But as I went around the country and asked some of the more integrated systems, what do they expect to see to really expand or leverage the primary care physicians, actually every one of them mentioned a need to redesign compensation. So if you said, what are the three major innovations for a shortage of physicians? One, physician extenders working in teams. Two, facilitated by electronic health record and more evidence-based clinical pathways. And three, a new compensation plan. All of which sounds individually a little mundane, but as our previous speaker said, good ideas are easy. Implementing good ideas are difficult, and they take time, and they rub up against culture of an organization, and they run up against institutional attitudes such as, well, we don't think that'll work here because we're different. As I do talks around the country, I always ask, if they're that one organization that's unique in the United States, because everywhere I go, people will say, well, that innovation won't work for us because we're unique. So, just the leveraging of primary care physicians and certainly other consultants. As I have seen, and this is some of the other work that we're doing at the university, some of the specialties are leveraging themselves, and that's my term, leveraging themselves much more effectively. For example, there's an orthopedic model that I was involved with where actually the first visit to the department is to a physician, but not an orthopedist. The first visit, non-emergency visit to the department is seen by family physicians who have an extra year of sports medicine training. They have protocols for the workup and the triaging as the patients present, and the disposition we found of first visit orthopedics is typically 3. Go home and ice it or heat it, go directly to physical therapy, or go to an orthopedic consult. So what we were trying to facilitate with a relatively simple innovation, one would think, is more ready access to the orthopedics department. By implementing this innovation, we were able to create a patient being able to have a first visit to the orthopedics department 36 hours after their telephone call. Now, these are non-emergent situations. The emergent situations would obviously go to the emergency room, but one of the problems for orthopedics, at least in the Twin Cities, is access. We were able to virtually guarantee 36-hour access to the orthopedics department. Now, you may say, well, that wasn't 36 hours to a visit with an orthopedic surgeon. Nobody ever called the orthopedic department and said, I want to come and talk to a surgeon. They would call with a problem. So that's listening to the patient. Now, if they needed to get to a surgeon, they always got to a surgeon. But our issue was to create excellent care, excellent access, and responsiveness appropriately to the clinical condition. So again, and every orthopedic surgeon would also work with 2 physician extenders. One would be a surgical assist, typically a clinical PA or a physician's assistant, and that surgeon would also have a physician's assistant that worked with him or her doing post-surgical rounds and dealing with pain management. So this is a study I'm doing right now with the federal government to focus on how some of these more innovative centers are creating much more productive physicians by what would appear to be relatively simple innovations. But again, as our previous speaker said, easy ideas are oftentimes more difficult than one may think to implement. Sixth problem or challenge, excessive unnecessary referrals from emergency rooms in rural areas to the referral center. Does that sound familiar here? I've talked to a number of physicians here who have told me we have too many referrals coming in here that perhaps aren't necessary. So here's some of the innovations there. Number one, the health system owns or in fact manages rural hospitals and may employ all the physicians. We had rural hospitals we owned and managed up to 200 miles away from our referral centers. We owned the hospitals, employed the physicians, and therefore controlled the environment. There's a very interesting innovation going on with a rural health system in South Dakota by the name of Avera Health. I was there last week. They actually have now created video hookups with all their emergency rooms, and before a patient is transferred or referred in, that physician in that emergency department at that rural hospital must have an actual video consultation by a board-certified physician, emergency physician at the main site. Now, that in and of itself isn't all that dramatic, but the other thing they did is in simple design issues, and Ryan talked about this, all emergency departments in the rural hospitals are configured the same way, down to the design of the cabinets and where materials are stored in the cabinets. So if an emergency room physician in a rural hospital has a question and is being video consulted by a board-certified emergency room, that board-certified emergency room knows where every piece of tape and gauze is in that emergency room where that other physician is working. So just standardization of the environment has created far fewer referrals. By the way, one of the studies we did for this particular problem asked one simple question. What was the principal driver of a referral from a rural hospital to the main center? The principal drivers we found talking to the physicians were the physician in the rural setting wasn't comfortable because he or she probably wasn't a board-certified emergency room physician. B, they actually wouldn't have had the staff available to take care of that patient if they admitted that patient. And 3, it was just simply easier to move that patient to the rural center and make the problem go away. It actually almost never had anything to do with the clinical complexity of the case in front of the physician. So when this particular rural health system took a look at this problem, they found that the innovations, some of them were more expensive than others. One, they needed to actually probably own and control the hospital. B, they had to employ the physicians. 3, they had to have video hookups. 4, they had to make those rural physicians comfortable taking care of patients that perhaps they would have shipped in or referred before. And 4, standardization of the design of the environment around the physician. And then they're on a very aggressive approach to training staff. So the nurses from that emergency department, just as you're doing here, will come into the main site for regular training. 7th problem, common problem we're dealing with, specialty care in short supply. Again, we really don't have any surpluses of physicians out there, although interestingly, I'm in the medical school faculty at Minnesota, and I'm starting to see fellows and residents that had no trouble getting jobs a few years ago are finding that jobs aren't as plentiful, and I actually don't know why that's the case, but it's just a little surprising. But as I mentioned, some of the innovations relative to this challenge are the leveraging of the physicians through A, teams, B, just the employment model, being able to employ all the physicians and staff in the same organization is an extraordinary structural help to this issue. Again, more evidence-based care best practices and care pathways, and again, relatively mundane, a change in the compensation plans. This is interesting, number 8, goes back to another clogged hospital problem. Well, I looked at one innovation which was very interesting, and I didn't bring pictures, but I will share them with our students. A particular high-volume tertiary quaternary referral center in the Twin Cities decided it needed to decompress its campus. It basically took all the ambulatory services and moved them to 200,000 square foot facilities 1 mile away from the hospital. So what they found is their efficiency was dropping off for their inpatient care because they were trying to use hospitals designed for inpatient care to treat a growing volume of outpatient care. And interestingly, if you study the economics of more integrated systems, and I have done this a number of times, the larger, more integrated systems such as yours over time actually generate more of their patient activity and revenue in the outpatient settings than they ever do in the inpatient settings. Yet many of us are trying to take an outpatient business and make it fit into an inpatient environment. So this particular forward-thinking center innovated by literally creating 400,000 square feet of specialized ambulatory space a mile away from its main campus. Now, a physician friend of mine led that effort, and he was in charge and on point, a physician executive. As you might imagine, he got complaints. The first complaints came from the finance people. The finance people said, well, you're just taking the business we already have and you're putting it in more expensive space. When you, at least in US dollars, when you fully equip a sophisticated ambulatory center with all the equipment and all the facilities, it'll run you somewhere around $400 a square foot to build and equip. So the finance people were livid. They said, this is a very bad financial condition, and it's a very bad situation, and we don't recommend it. Well, what they didn't know is what they didn't see. And what they didn't see is their outpatient business was really constrained by the physical facilities they had. The moment they moved them out to more expansive ambulatory centers, their volume and demand actually doubled. So all of a sudden, what the finance people thought was a bad financial decision actually became a very profitable capital investment. The physicians came to this physician leader and complained as well. They said, you're just going to make us more inefficient, because right now, with everything's on the same campus, we can run from inpatients to outpatients, and we can move around the campus fast. His response was, you're just simply confusing frenetic behavior for efficiency. And you're going to need to learn how to schedule yourselves differently. You're going to need to work as teams, as departments. And if you schedule yourselves differently, you'll find that your efficiency will go up, not down. And he was absolutely right. Ninth challenge that we're all seem to be dealing with is chronic disease management. As was suggested by myself and my colleagues, over 3/4 of the healthcare dollar in the United States is spent on the management of chronic disease, yet our care models have been more cross-sectional than longitudinal in nature. So, for chronic disease management, what are some organizations do? First of all, the patients are identified up front in the electronic record. Who has the chronic conditions? What are the clinical best practices? We should be proactive in bringing them in for appointments. We will assign them to teams. Maybe the patient doesn't see a physician for at least a year while they're being managed by the team of other clinicians. They may be enrolled in support groups that we're using social networking to tie them together. For example, if you have a patient who's had a stroke, that patient has a one-to-one interaction with a physician, but what the patient never knows is that physician may have treated thousands of people just like that person. And that person could benefit from being connected with those other people for social support and social support. So what we're seeing is a lot of focus on chronic disease management using tools that have nothing to do with the use of physician time, being with a focus on managing longitudinally, getting better results at lower, as I said before, total cost of care. 10, elimination of unnecessary visits to physicians. From what I can tell, all of you have challenged schedules. The issue is, how do we prevent unnecessary visits? One organization is having all scheduled visits previewed by a nurse before that visit occurs to determine whether that visit could actually be managed without a visit by connection through e-connections, for example. So there's, again, approach of teams. So I went to Health Partners, and I asked the physician medical director there, give me an example of what you're doing for the management of diabetes to more effectively manage patients' quality of care, clinical indicators, and cost over time for diabetics. The goal, as you might expect, optimal management of diabetes. The strategy, manage patients' goals on 5 clinical measures. Hemoglobin A1Cs less than 7.9, LDL less than 99, blood pressure less than 139/89, no tobacco use, regular aspirin user. These were the 5 clinical indicators that they used as if achieved, would be effective in managing diabetics over time. The clinical goal, all identified patients achieve goals on all measures. The rationale, to prevent medical complications, heart attacks, amputations, unnecessary hospitalizations. The process, a team approach to management using all those other tools that I had mentioned. Their results, and this is interesting, if they took the population that they identified that would be available for this approach, only 5% of that population would have been effectively managed on all of those 5 clinical indicators. Through the course of these innovations, care process innovations, they have moved that 5% to 42%, which by definition means that 58% is still outside what they think is effective management. And then the physicians share their best practices with their colleagues. And you've heard a number of times mentioned here the effectiveness of communication of innovations. I noticed we implemented a similar approach in our organization, and we found very similar results. And as you might expect, we saw physicians who were doing very well with their panel of diabetics and others doing not so well. Some were above 42%, some were below 5%. First thing we did is share the data. The physicians who were at the 5% level would say, well, you know, everybody's having problems with management diabetics. I'm no different than my peers. Actually, you are. The data would show that you have peers that are operating several standard deviations better than you are. The next most important question then is, how do they do that? Well, the first retort was usually, well, the patients are different. My patients are sicker. Well, actually, they weren't. So once you clinical adjust for acuity, comorbidities, related issues, they found that, in fact, they weren't different. They were just being treated differently. So the ability to take an organization like yours, through informatics, be able to answer important questions, share that data, use that data to create communication between you, you can have some very dramatic results for what would appear to be relatively mundane and almost uninteresting innovations. And I guess that's sort of the difference, from my opinion, on healthcare delivery innovations and what Apple does, for example. You know, somebody mentioned to innovate, you have to give the customer what they need. I have never needed any innovation or invention by Apple, but once I saw it, I wanted every one of them. So there's a big difference between need and want. And in healthcare, I think we by definition, probably have to approach innovation in a little more incremental way, because as I said earlier, people's health and lives are at stake. We can't afford big misses. But the fact is, what you'll find, and I think many of the other speakers have said this, everything on this list of innovations I have given you, individually or collectively, probably is not that exciting. But you add it all up, put it together and implement it through leadership and management, and it produces some pretty interesting and exciting results. So my goal with this shorter session was to respond to Dr. Tamimi's question of what's going on, and can you tell us how the U.S. is dealing with some of the more mundane issues. So thank you very much for this opportunity.